Hello everyone, welcome to HIM 225. In this lecture we're going to be covering chapter 23 in your textbook. If you will, please turn to page 569. Now in this chapter in our textbook we're going to be covering chapters 16 and 17 in ICD-10. As always, I suggest that you take a look at the learning objectives and the abbreviations and acronyms for both of these chapters, for this chapter, and also take a look at the glossary terms at the end of the chapter, and take a look at the homework assignment before you read the chapter and begin listening to the lectures. On page 570, we begin by looking at the coding guidelines for chapter 16. And in the tabular, as we look at chapter 16, there's a note here, and it tells you that codes from this chapter, and this is chapter 16 only, not 17, but codes from chapter 16 are only used on newborn records. They never go on the maternal record. So, and this includes conditions that have their origin in the fetal or perinatal period before birth through 28 days after birth, even if morbidity occurs later. And we do have an excludes note 2 here, so these are conditions that you would code in addition to the codes from chapter 16. Now, as we look through this section list, I'm not going to read all of these to you, but you can see the range of codes that are included here. Notably, we have codes related to the newborn being affected by maternal factors and by complications of the pregnancy, labor, and delivery. We're going to spend a lot of time talking about these disorders of the newborn related to length of gestation and fetal growth. There are codes for birth trauma, infections specific to the perinatal period. And so you can take some time to go through this section list, and then we can go and look at some of the different categories. So in your textbook, it tells us that the perinatal period is before birth through the 28th day following birth, and that these codes from chapter 16 are never used on the maternal record. The other important guideline is that when we are coding the actual birth episode of a newborn record, the code from category Z38, which is the live-born infant code, is assigned only once. It's assigned to a newborn at the time of birth, and it is the principal diagnosis for that newborn. If the newborn's transferred to another hospital, the code from category Z38 is not to be assigned or used by the receiving hospital. That code from category Z38, in the index to find these Z38 codes, we actually go to newborn. And you can see that there's a Z38 code. We also have many other codes from chapter 16 listed here. We're not going to be confused by those P codes because we're looking for the Z codes that are assigned to these patients when they're born. And we can go down and we will find the subterm born in hospital. Where Okay, born in hospital Z38.00 by cesarean Z38.01. If it's a twin birth, we would put twin. If it was triplet, we would put in triplet. But let's go and look at this particular category in the tabular. Sometimes it's easier just to come to the tabular and find the appropriate code that you need. C38.00, single live-born infant delivered vaginally, delivered by C-section. You can see the code for born outside hospital, single live-born infant unspecified, and then we go down to the codes for multiple births. And so these are the codes that would be the principal diagnosis code for any newborn, always. Now you can certainly assign other codes along with Z38, category Z38, but this will be your principal diagnosis code. So let's look at this first example. The patient was born in the hospital via C-section. So we know that we're going to have a code from Z38.0, and then we're going to pick the 01 to reflect that this baby was delivered via a C-section. Then the other condition that we have is neonatal jaundice. In the index, we go to jaundice and then newborn, and the default code is P59.9. Now, there may be reasons documented for that infant to have jaundice. They may have an ABO incompatibility. There may be other reasons documented for the jaundice, and if those are, then you can assign the specific code. But if the only thing that you have is a documentation of jaundice, then you're using the default code. Now, the next guideline tells us that if there is a condition that originates in the perinatal period and continues throughout the life of the patient, then the perinatal code should be used regardless of the patient's age. So age is not a factor in the use of codes from Chapter 16. And in this example, we have a 3-year-old who's seen in the pediatrician's office with a diagnosis of bronchopulmonary dysplasia. They've abbreviated it BPD. In the index, I can go to dysplasia. It does say C anomaly, but in this instance, I specifically find bronchopulmonary perinatal with the code of P27.1, which I will verify in the tabular. And those are my codes. Now we have guidelines on the birth, whether or not a condition is coded as being a result of the birth process or whether it's a community acquired condition. And basically, this guideline tells us that if a newborn has a condition that may be either due to the birth process or community acquired, and the documentation does not tell us which it is, the default is due to the birth process, and a code from Chapter 16 should be used. If the condition is community acquired, then a code from Chapter 16 should not be assigned. If you're ever uncertain about whether or not the condition is a result of the birth process or community acquired, then you should query the physician. So let's look at the top of page 571. A 1-week-old baby is admitted for cough and fever, and on the discharge summary, the physician documents pneumonia. Now, in the index, if we go to pneumonia neonatal, we see that the code is P23.9. When we verify that code in the tabular, it tells us that this is congenital pneumonia unspecified. In the next example, we have a 1-week-old baby admitted for cough and fever, and on the discharge summary, the physician documents congenital pneumonia. So in the index, if I go to pneumonia and then congenital, you'll see that, again, that default code P23.9. But what I want to show you here is that it has due to, and there are specified bacteria, just like you would see in pneumonia, J18, in the pneumonia respiratory chapter, for codes that are specific to the organism that may be causing the pneumonia. So if you have that specificity, then you would choose these codes. And with these codes, these are combination codes. So if in fact the organism, so if the patient, the neonatal, has a pneumonia that falls into one of these subcategories that does not include the organism, then you would use an additional code to specify that organism. Just want to make sure that you are aware of that. And in this third example on the top of page 571, a 1-week-old baby is admitted for cough and fever, and on the discharge summary, the physician documents community-acquired pneumonia. So in this instance, we're assigning the default code of J18.9, and we are not assigning a code from Chapter 16. The next guideline tells us to code all clinically significant conditions. So a clinically significant condition that is noted on routine newborn exams should be coded. A condition is considered to be clinically significant if it requires clinical evaluation, therapeutic treatment, diagnostic procedure, if it extends the length of the hospital stay, if it increases nursing care or monitoring, if it has implications for future healthcare needs. Now, this is a really important thing because conditions may be identified for a newborn that are actually not addressed during that newborn stay. They plan to have the patient come back at a future date to have that treated. One of the common things is maybe an undescended testicle, or maybe the patient has some type of heart defect. And we have a note here, the perinatal guidelines listed above are the same as for the general coding guidelines for additional diagnosis, except the final point regarding the implication for future healthcare needs. Codes should be assigned for conditions that have been specified by the provider as having implications for future healthcare needs. So in this example, the physician was born via a vaginal delivery and suffered a fractured clavicle caused by the delivery. So we're going to have our Z38.00 single live born infant as our principal diagnosis code, and then we are going to code that birth injury. So in the index, we're going to go to fracture, traumatic, clavicle, and then birth injury. You'll see this code P13.4. We verify it in the tabular, and it tells us in this category in Chapter 16 for birth injuries to the skeleton, we can see that this is a fractured clavicle due to the birth injury. Now, the next guideline that we're going to look at and the codes that we're going to look at are those times when a patient is observed not a patient, a newborn is observed for a suspected condition that was not found. And we had this all the time when I was coding in the hospital. It would extend the length of stay. Many times the insurance payers would not necessarily want to cover those days, but it didn't impact whether or not the baby stayed in the hospital. So these codes were developed to actually capture those circumstances. So we assign a code from category Z05, and I've pulled it up here in the tabular for us to look at. This is observation and evaluation of newborns and infants for suspected conditions that are ruled out, to identify those instances when a healthy newborn is evaluated for a suspected condition that is determined after study not to be present. Do not use a code from category Z05 when the patient has identified signs or symptoms of a suspected problem. In those cases, you would code the sign or the symptom that the baby has. A code from category Z05 may also be assigned as a principal or first listed diagnosis code for readmissions and encounters when the code from category Z38 is no longer applies. So the baby's born, they're discharged, they come back. We would not use the code from category Z38. So that is when a code from category Z05 would be appropriate. Codes from category Z05 are for use only for healthy newborns and infants for which no condition after study is found to be present. So basically there was nothing wrong with them. They had to rule it out. They needed to observe them. But in the end, they didn't have whatever the condition was that they thought they might have. A code from category Z05, and it is an O, not a 0. I apologize. Z05. It's not an O, it's 0. So a code from category Z05 is to be used as a secondary code after the code from category Z38 when it's the baby's birth record. So let's look at this example. A male infant was born by a precipitous vaginal delivery and was observed for complications related to a precipitate delivery, but no complications were found. So it's a single live-born infant. So the principal diagnosis is going to be Z38.00. Now, in the index, we go to newborn, or we're at observation newborn. And you can see that we have a suspected condition and ruled out. Now, if you look at this, we don't see anything specific to precipitous delivery. So we are going to be choosing specified condition NEC Z05.8, and we can verify that in the tabular. Now, your question for this lecture is from exercise 23.1. And you're going to be answering questions 3 and 5. It's on page 573, so number 3 and number 5 in exercise 23.1, and that is a multiple choice question, I do believe. And that will conclude this first lecture for chapter 23.